Okay, so I'll read out Jan's bio. I'll sit down, and then Jan is going to go through his wonderful lecture, and then we'll have Q&A at the end. Sound like a plan? Lovely. Here we go. So Jan Ramaekers is from Maastricht University in the Netherlands. He's a professor in psychopharmacology, and his research combines the methods from psychopharmacology with forensic toxicology and cognitive neuroscience to determine drug-induced changes in human performance. In his work, he focuses on the impact of different substances of use and abuse, including cannabis, stimulants, opioids, novel psychoactive substances, and psychedelics on neuronal networks and human cognition. His work bears relevance in the context of drug development and therapeutics and in legal settings when evaluating the impact of drug exposure on human function. Jan, over to you. Welcome.
Thank you, David, and thank you for that introduction. I was about to say that the keys were mine, but I think I'm already too late. So today, I want to talk a little bit about the psychedelic experience as such and how individual such an experience actually can be. So I called my presentation The Idiosyncrasy of the Psychedelic Experience. And relevant in that context is a finding that has been replicated many times in a couple of studies, which is that the intensity of the psychedelic experience seems to be predictive of therapeutic outcomes, in the sense that the more intense a psychedelic experience, the more likely that there will be a beneficial outcome in terms of clinical improvement. And we've seen this, for example, in the treatment of depression, but also in the treatment of anxiety and addiction. So this seems to suggest that the psychedelic experience as such, so the content of the psychedelic experience actually might matter. And this, of course, feeds into a discussion that is ongoing at the moment, where the debate really is, now, what do we need in order to achieve therapeutic output improvement? Do we need the psychedelic experience, or do we just need the underlying pharmacological changes like neuroplasticity? So I think today I will show some of the data that maybe would favor the first position, but would not exclude the last either. And what is important about the psychedelic experience as such is that we can also now demonstrate that it is related to biological changes that we, for example, can measure in the brain using brain imaging techniques. So here is one example from our own lab. So when measuring the psychedelic experience, for example, after treatment with psilocybin, there's a couple of tools that you can use to measure that these subjective effects. For example, the 5-DASC or the EDI, the Ego Dissolution Inventory, or the Mystical Experience Scale. In our study, we've used the 5-DASC, and that has a couple of dimensions. I think one of them is oceanic boundlessness, which is sort of related to the mystical experience or the ego dissolution scale. So what we found in our experiment is that there is an increase in oceanic boundlessness, visual restructuralization after the intake of a moderate to high dose of psilocybin. And in that study, we also conducted brain imaging work. Among that, we used MRS spectroscopy, which is a measure to quantify concentrations of important neurotransmitters in the brain, such as glutamate and GABA. And what we found, interestingly, is that the content of the psychedelic experience is actually related to regional changes in glutamate in the brain. For example, increments in ego dissolution or increments in oceanic boundlessness were strongly correlated to decrements of glutamate in the hippocampus. And likewise, increments in anxiety during the psychedelic experience, these were correlated with positive increments in glutamate in the medial prefrontal cortex. So clearly, this suggests at least that changes in the brain are actually also representative of changes in the subjective state as we experience it. And another finding that is pretty common in studies that have looked at functional connectivity during a psychedelic experience is that there seems to be an increase in connectivity be between brain networks, hyperconnective state. So there's a decrease in segregation of these networks and a decrease in modularity. And this is what is depicted here in panel A and B of this slide, which was taken from the psilocybin study that I was just talking about. But this is static connectivity, and another measure that we looked at is called dynamic functional connectivity. So basically, you're looking at a time window and you're trying to identify patterns of brain activations that keep recurring. And in our study, we found 4 recurring patterns, of which the most prominent one was pattern 3 in this panel D. And this is, as you can see, when you're looking at the matrix of the whole brain connectome, that is basically entirely red. And that indicates that this is a pattern, a state in which people achieve hyperconnectivity between all brain regions that we were interested in. And in panel E, you can see that if you follow the transitions across these patterns, that the pattern 3 was the pattern that people transitioned into the most. So we have this subjective state that is the altered state of the psychedelic experience. We have these changes in brain connectivity. And then the question is, are these then also related? So we did basically a canonical correlation analysis, where we were looking whether these transitions into pattern 3 were related to the subjective feelings as recorded with the 5-task questionnaire. And basically what you're looking at here in panel A and panel B is that these transitions to pattern 3, they are associated to a latent factor that is underlying both the brain imaging data as well as the subjective state. So here you see that the oceanic boundlessness variables, the individual factors that contribute to that, are actually associated to the transitional states in the dynamic functional connectivity, so the hyperconnectivity. So 2 examples showing that functional connectivity and changes in glutamate actually underlie the psychedelic state and are relevant for the intensity of that exact experience. So we figured that if the intensity of a psychedelic experience matters, then it's probably also a good thing to consider that when designing a dose regimen for people that are treated with a psychedelic. And we sort of played around with that idea in a study with 5-MeO-DMT, a short-acting, fast-acting psychedelic, where we had the intention to dose each and every individual to a maximal psychedelic experience. So that basically meant that if you give somebody a single dose, so let's say we would start with a lower dose, and that person would achieve a maximal psychedelic experience as measured with a peak experience scale, then this would be a perfect dose. But if an individual did not achieve a peak experience, then we would say, okay, maybe we have to increase the dose a little bit in order to achieve that psychedelic experience maximally. And if a second dose would not be enough, then we could even go to a third step and increase the dose a little bit more in order to find out whether that would achieve the maximal psychedelic experience. So we used a scale that we devised ourselves. It's called the peak experience scale. And it basically consists of 3 simple questions that are about the loss of control, the amount of the intensity of the experience, and the profoundness of the experience. We would sum these scores, and if somebody exceeded the level of 75% across these scales, we would call that a peak psychedelic experience. So basically, this is an individualized dosing regimen that we applied in human studies. And we started out in healthy volunteers to get a better understanding of this concept and also a better understanding of the individual variability that you can expect. And in this healthy volunteer study, we started with low doses of 5-MeO-DMT, so this is 2 milligram, and then we actually ascended to 6, 12, and 18 milligrams. In each case, these were individual doses. And then finally, we had this individualized dosing regimen, here called IDR, where we would use that dose escalation program schedule as I've shown you before. So typically what we see in the left panel is that when people were treated with 2 milligrams, so a very low dose, there wasn't much of a psychedelic experience. If you increase the dose to 6, then you can already see there appears to be a lot of individual variation. Some didn't respond at all, but some actually achieved the peak experience. That same pattern occurs in individuals that receive 12 milligrams and 18 milligrams. But that was different in those 4 subjects that received an IDR dosing regimen, because here you can see that everybody actually achieved this peak psychedelic experience and that the variance between them actually seemed to be reduced quite a bit. And most of these, 2 of them had 6 plus 12 milligrams, one had 6 plus 12 plus 18 milligrams, and one had only 6 milligrams in that treatment regimen. And if you compare our peak experience scale to a more well-known and validated scale, the mystical experience questionnaire, you see basically the same pattern, indicating that what we were measuring with the peak experience scale was quite predictive of what other scales would have measured. So I think this shows that the IDR as such is a good idea and can actually help reduce the individual variability. So we applied the same idea to a study in treatment-resistant depression. So we invited 16 patients to enter the study. 8 of those went into the first phase, where they would receive a single dose of either 12 milligrams or 18 milligrams. And in the second phase, we would have 8 patients that would receive 6 plus 12 or plus 18 milligrams, according to that IDR schedule. Our primary endpoint, particularly in phase 2, was the MADRS scale, and the primary endpoint was set as a MADRS score below 10 at day 7 after treatment, meaning that people would be in full remission. But we measured the clinical measures at screening, at 2 hours prior to the administration, 2 hours after, the day after, and 7 days after. So here we're looking at the data of the phase 1 part. So meaning we had 4 people, patients treated with 12 milligrams and 4 with 18. And if you look at remission, response, and improvement rates, we see that everybody improved, but that response and remission rates were around 50%, which is still quite a nice result. But on the right panel, you see the absolute values at screening. So everybody had a MADRS score above 30. That was also the case at baseline. Then at 2 hours, you see a very sharp decline that is even more prominent at day 1 after the treatment, and it's also still prominent at day 7. So there was a very significant reduction in the symptoms, but overall, the group as such was not in remission. There were some individuals in remission, but not at a group level. But if you looked at the IDR treatment regime in the remaining 8 individuals, then we see that the numbers are actually a bit more favorable, in the sense that still everybody improved, but now remission and response rate went up to 87%. So basically 7 out of 8 patients went into remission on day 7. And this is also what you can see in the right panel very clearly. So these are the scores at screening, at baseline, at 2 hours after the administration, and then at 1 day and 7 days after the administration. So again, showing here that that using an IDR regimen, an individual-based treatment regimen, you are actually able to reduce the variance in the intensity of the psychedelic experience, and therewith also the variance in your clinical treatment outcome measure, which I think is important. This is not to say that the psychedelic experience or the intensity of that experience is the only factor that would be of relevance when explaining the therapeutic outcomes. I won't go into a deep details, but of course we've heard the stories. It matters that, for example, in the past we have seen that cytokine levels are actually very high in patients with depression, and also BDNF levels in patients with depression are generally low. And we've seen that after treatment with psychedelics, that BDNF levels can actually increase, and also cytokines, pro-inflammatory cytokine level can actually decrease. And evidently, these factors would also weigh in treatment outcomes. An example that I want to show in this context is some data that we published last year. So here again, we're looking at a psilocybin study, healthy volunteers, that acutely show a decrement in TNF alpha and an increase in cortisol level because it's a stress response. And then at 1 week after that treatment with psilocybin, we see that there's a decrement in IL-6 and CRP, for example. And these decrements in cytokine levels were actually associated to improvement in psychological well-being that we measured in these healthy volunteers at 7 days after the treatment. So indicating that there's more factors that play a role in the therapeutic response, at least the ones that you can measure subacutely. Importantly, in this context is also to note that the change that we noted in TNF alpha acutely was very much associated to the changes that are previously reported in hippocampal glutamate, indicating that changes that you see in peripheral levels are also communicating with changes in the brain that you measure at a central level. So overall, there may be more factors than just the psychological experience that weigh into this therapeutic outcomes. I've tried to list them here shortly, so we can look at behavior. I spoke about it. Centrally, there are changes in brain networks and neuroplasticity and levels of glutamate. And also at the peripheral level, there is this immune system that we know is malfunctioning in depression, for example, and that may actually change under the influence of glutamatergic changes in the brain. So and from that, I want to make a small jump into how individual a psychedelic experience is. So now I talked about individual differences, but how similar is, for example, my psychedelic experience to yours. And we saw an opportunity to address that specific question in a study that we recently conducted in collaboration with the Santo Daime Church in the Netherlands, who approached us for a collaboration. And so we set up together with them an observational studies that had 2 treatment conditions, one where they didn't drink and one where they drank their daime, so their ayahuasca brew that they would normally drink. We agreed with them that they would dose themselves as usual, so they would drink as what they would normally drink in a Santo Daime church gathering. And after drinking, we invited them to come over to our laboratory to do a resting state fMRI, to measure functional connectivity, to do spectroscopy, again to measure glutamate and GABA. And we would also take blood to measure pharmacokinetics and metabolomics. And these were very experienced users, which is good to understand. And on average, they had been drinking ayahuasca on 563 occasions, which is an awful lot. I don't think many people in the audience will need that quantity. So they brought their own daime. You can see a picture of it right here. They drank as per usual. We had to, of course, they were not participating in a regular, routine daime gathering because they had to come to our laboratory. So we organized it in such a way that there would be 6 people coming over for a weekend. And then on a Saturday, they would not drink and we would have them in a scanner. And on a Sunday, they would, so the 6 people would have a small gathering. They would go through their common rituals like singing, praying, dancing, before they would go into the scanner. But of course, they didn't go into the scanner at the same time because we only have one MRI scanner. So I gave them a schedule basically, on which dictated them to drink at 90 minutes intervals so that we could do 6 fMRI scans back to back on a given day. So we had 6 participants in a weekend, and we needed 4 weekends in total to complete the study with 24 volunteers. So we had samples taken of their DIME to look at the content. Of course, there's DMT in it and a couple of harmalines, as we've all known, just to show you. And on the very left, you see the dose that people took. And as I indicated, people drank as per usual. And there was quite a variability in the dose that individuals took. So the lowest dose was around 11 milliliters, and the highest dose was around 40. So basically 4 times as much as the one that took the lowest dose, which is fine because as I understand it from some DIME members, there is actually quite a bit of individual difference in how much of a dose somebody needs in order to be able to get to this common psychedelic sphere that they're trying to achieve. And this is also the reason why we don't find a correlation between the dose across these individuals and the concentration that we measure in blood. So independent from the dose that people took, the actual concentrations in blood were about similar, indicating that there are individual differences in metabolism or genetic profiles that they actually define how much of the concentration can be measured in blood. We looked at their psychedelic experience. So again, we used the 5-task. We saw increments in oceanic boundlessness and also in visual restructuralization. And also the scale of ego dissolution inventory actually increased quite a bit. And these subjective ratings were significantly positively correlated to the DMT levels that we found in their blood. And that also makes sense because DMT is the psychoactive substance that we would expect to cause these altered states of consciousness. We also looked at some cognitive tasks, in particular mental imagery. Overall, we did not find many changes in their capacity for mental imagery on baseline days and active days. Maybe because they were very experienced ayahuasca users and therefore more in control during the psychedelic experience than more naive users of ayahuasca. But even despite the fact that we didn't find large differences at the group level, we did see that performances on these tasks, at least some of these tasks, were correlated to the DMT levels in blood. We see that, for example, in terms of perspective shifting and also in terms of cognitive flexibility. That actually decreased a little bit during the ayahuasca treatment day. So, but then the question is my experience the same as yours? So in order to address that question, we looked at our functional connectivity data. We had resting state intervals of 12 minutes. And we basically divided them in 2 sets, the first part of 6 minutes and the second part of 6 minutes. And we correlated the 2 sets to each other. So, and if you do that for your individual data, you get a measure of what we call I self. So basically, how much does my signal during the 6 minutes correlate to my signal in the second part of that experience, so between 6 and 12 minutes. And you can also do that. You can also compare your own signal to the signal of others that are also participating in this experiment. And this would be an index of your similarity to others. So this is basically what I've tried to explain here in this matrix. So we have done 2 measures. One is I self and one is I others. And what we typically see if you compare if you correlate your signal in the baseline, there is a high correlation. If you correlate your own signal during the ayahuasca experience, there is also a very high correlation. So I self is not changing. But if you're comparing your own signal during the baseline to your own signal during the ayahuasca experience, then you see that that signal is actually dropping. So you become less identifiable as a person. And if you compare yourself, and this is the interesting part, I think, if you compare your own signal to that of the others, then what we actually found is that there's an increase in that parameter that we are calling I others. So your own signal is becoming more similar to the participants in this study, and that were all the Santo Daime members. So this is interesting, because then the question arises, so what's causing this? Is it because people were all drinking ayahuasca? Is that why the signal is becoming more similar, which is a possibility? Or is it perhaps the fact that Santo Daime members engage also in rituals that are common to them and that they always use to get into this common psychedelic state that they are striving for? So, meaning dancing and singing, praying. These are rituals they would normally use, but then again, in our study, they were lying in the scanner as individuals, right? There was no contact with any other members of the Santo Daime community. But when we asked them afterwards, many of them actually said that they were using these techniques even on an individual basis while lying in the scanner. So they were mentally singing, they were mentally rehearsing some of the prayers that they would normally use. So apart from the fact that they all drank ayahuasca, there is this possibility that it's actually the rituals that they have sort of made themselves, or that are commonly used, that might explain why they become more similar to each other in this particular experiment. And in order to test that idea, we went back to our psilocybin dataset that we then, where we had conducted the same analysis, again looking at this I self parameters or the I others parameters. And here, typically, what we see is that the people become less similar to others, so they become more idiosyncratic, basically indicating that in this experiment, under the influence of psilocybin, in a group of people that they have never met, they didn't know who was participating in this study, you see that people become actually more individualized and less common and show less similarity to the others. So what we were observing in the Santo Daime study, I guess, is not just the ayahuasca psychedelic as such, but also the fact that people are engaged in rituals that they use to get to a psychedelic state. And then finally, a study with which I want to conclude this presentation is a study that was just published a couple of weeks ago, where we looked at inter-individual differences during low doses of LSD, so also referred to as microdosing in many occasions. So this is a healthy volunteer study. We had two groups of 24 and 23 individuals that either received placebo or LSD. And they went into a 4-week treatment routine. During the first week, we had a baseline measure, so there was no treatment yet. But then in the second week, we started microdosing with 15 micrograms of LSD or placebo on Monday, first dose, then Thursday, Friday, the second dose. That would be repeated in the third week. Then in the fourth week, we would have a follow-up, 1 week after completion of the 4 dosings of LSD. And the boxes that are shaded in gray indicate the days that we took cognitive measures, but also neurophysiological measures, such as EEG. We were interested in resting state EEG, but we also looked at visual long-term potentiation measures and a couple of more. I won't show all of those, but a couple. I would like to start with the resting state EEG. So we've seen before in previous studies with psychedelics where full doses were given, similarly also ketamine, that we see a decrement in EEG power for low frequency bands such as delta, theta, and alpha bands. And these are actually indicatory of stimulatory effects on the brain of this psychedelic. And what this study is showing is that you can achieve this state of stimulation already with very low doses of LSD. What is interesting is that these effects were prominent at the first dose, at the fourth dose, but in case of the delta waves, actually, we also measured those at a 1 week follow-up although the effect size was remarkably less than during the actual acute test date. But still, it seems to indicate that some of these effects that are produced by LSD linger on for quite a while. So this might be a reflection of neuroplastic changes that are underlying or that are occurring during that microdosing regimen. What we also found was that the changes in EEG power were quite related to baseline EEG performance to begin with. So people that were low in arousal states profited the most from a microdose. So they actually showed the largest decrement in EEG power, again indicating that individual differences are quite common and may define quite a bit the actual response to whatever dose of a psychedelic. A second paradigm that we looked at in this study is called long-term visual potentiation. It's basically a measure of learning, memory, if you wish. And here we find, again, an effect of LSD, a low dose of LSD, but in this case, it's inhibitory. So the ability, the capacity to learn or memorize a pattern of visual information is actually blunted. And we found that actually on the dose 4 of the LSD, but we did not find it, for example, during the follow-up. And also here, we found that those individuals that had the strongest learning memory performance at baseline suffered the most from the blunting effect of this low dose of LSD. So basically, I think what these two examples show is that these individuals that have like the most room for change, for either improvement or impairment, show the largest effect sizes of this low dose of LSD. So in this study, we also asked whether people were able to guess whether they were assigned to placebo or LSD, which we did because there's quite some literature indicating that many of these effects that we see with low doses of psychedelics might actually be placebo effects or expectancy related. So in order to get an understanding of that particular question, we asked people after dose 1 and dose 4 to indicate which dose they thought they had received. And if we compared the frequencies between those that had correctly guessed and those who did not, we actually found no differences. So it was about equally divided across 50%. So suggesting that this is a study that was well blinded, that people didn't really know in which condition they were, and that the changes that are presented here are actual changes that are pharmacologically related and not so much related to psychological expectancies of individuals. And with that, I want to conclude my presentation by stating this conclusion that individual difference matter. Thank you very much.
Thank you, Jan. Wonderful presentation, fantastic slides. And we've got, around 12 minutes for questions. We've got 2 stations set up in the middle of the room, so feel free to line up in an orderly fashion with your questions. And I think maybe I'll ask a question in the meantime. Yeah, so feel free to line up. Jan, looking at your work, obviously you've worked with a number of different substances, compounds, and you were talking about the effect size being somewhat significant and dosing really being very significant throughout all of your studies. I wanted to just mention the work of Dr. or Professor Gull Dolan and her work, and how do you sense any of her models, theories relate to what you've been finding in your lab, particularly around effect size and the duration of the psychedelic journey, and anything you've seen around kind of critical learning periods as well?
Yeah, so this is, I mean, it's interesting. I do think there is a connection with her work in the sense that, well, basically she predicts that the duration of the psychedelic experience is predictive of the length of the critical window that maybe people can use to train certain behaviors, for example. It would be an opening to implement cognitive behavioral therapy, I guess, in order to sustain a psychedelic response or a clinical response. I think that's where I see the best connection, because we know that that a psychedelic experience as such has a clinical outcome in terms of improvement, but we actually also know that it won't last forever. So we have to look for ways to sustain that response. And I think this is where Dolan's work actually comes in very neatly. And there are several ways to maybe address this question. I mean, one approach could be to redose and find out whether a redose would actually be as strong and as efficacious as a first dose. But I could also imagine that using that critical window that Dolan identified, you actually offer something else to sustain a response. I don't know, it could be mindfulness, could be cognitive behavioral therapy, it could be running or dancing. There's other, many forms that you could think of that potentially could be used to interact and continue on the therapeutic response that was triggered by a psychedelic.
Thank you, Jan. And the time that we have is a little bit less than originally I thought, but we've got time for one question. There's just someone at the back there. If you want to see if that microphone's working. It doesn't sound like it. Let's see if we can get it to work. Give it a tap. Oh, you have to just turn it on first. Little slide button. You just slide up to the green.
Working now?
Yeah,
Okay.
thank you.
Hi, thank you. I'll be as fast as I can. My name is Signe Goldman. I run a psychedelic-assisted psychotherapy clinic in the States, and we have several tracks. We have people who just get ketamine. We have people that get ketamine with psychotherapy. We have people who do ketamine plus therapy, plus a combination of what you would call ritual or ceremonial pieces.
Yeah.
And so I'm interested in this comparison. I also talked to Dolan about this idea of ritual and ceremony, holding open the critical window. So that I was also interested in the last question. So my curiosity is that people who come from what we'll broadly call the shamanic world understand that ceremony, especially sonic drivers, music, rhythm, dance, do create an altered state. And I'm curious if there are MRI studies that you're aware of that show you what that looks like in the brain, in order so that we can tease that apart from what the contribution is from the medicine, and what are the brain changes that are just happening due to what we'll broadly call for now ceremony.
Yeah, I don't think there are studies that particularly look at this question in a therapeutic context. So in like patients who are being treated with a psychedelic, there is some fundamental research, I think, that at least looks at the contribution of music to the altered states of experience. But these are usually subjective studies. But a systematic study using fMRI, I don't think exists yet. We have some data actually that we haven't analyzed because in this study that I was talking about, we did actually also offer music at some part during the scan session to address exactly that question. So how would music contribute to that psychedelic experience that they're already in? So maybe, I don't know, in 6 months or so, I can have a better answer to this particular question. And as a comment to the rituals, so I agree that we know, for example, from the psychedelic community, that rituals can actually shape the psychedelic experience. And I think this could be particularly useful in the context of group therapies, for example. Right now, most of the psychedelic treatment programs, I think, are based on the individuals. Maybe that's different in your institute, but I could see how music and other rituals could actually work at a group level when you want to sort of maximize the psychedelic experience, not at the individual level, but as a group. So this is some ideas I know that some groups are sort of looking into. Because that would be a way, maybe also to have like more efficient, or maybe less cost intensive therapies or treatment programs relative to individual treatments.
Thank you, Jan. I'm afraid we don't have time for any more questions, but thank you very much, Jan Ramaekers. This has been a wonderful presentation, and thank you for all the wonderful research you're doing.
My pleasure. Thank you.
Okay, and everyone, please stay seated. Our next talk is